Continue our grand rounds this morning. It really is my distinct pleasure to present to Dr. Hansen one of the highest recognitions from the University of Utah. And as individuals complete their tour of duty, there is the option to petition the President, the Board of Trustees, and the Faculty Senate for emeritus status. And so it's my distinct honor and pleasure today to give Karen the Certificate of Emeritus Status. And so on behalf of our new president, Dr. Ruth Watkins, and the Board of Trustees of the University of Utah, and the faculty of the University of Utah, I'd like to present you with your Emeritus Certificate, which is in recognition of your passion, your commitment, and your promotion of the University of Utah over the decades. Dr. Hansen. And of course, to me, this is poignant as well because I have known Karen now, I calculated, for about 42 years because we were both at the University of Nebraska in the mid-90s. It's also our honor to have Dr. Tony to do her introduction.
Good morning. I'm really excited to introduce the first annual Karen Hansen, we're not memorial because she's not dead, right? Honorary Grand Rounds. And we chose April specifically because April is Child Abuse Prevention Month. And it's a busy month for child abuse pediatricians. We were all talking about all the different engagements that we have last night because we get called to talk all over the place to increase awareness. I hope we're all aware of child abuse and the prevalence in our society over the course of the year. And I promised that I would not embarrass Karen, but I wanted to explain why we chose this as our way of recognizing her contributions. So I've known Karen for many years, not since the 70s because I was in grade school, but the, sorry, sir, excuse me. But the first time I remember seeing Karen, she was speaking at a national conference, and I remember thinking, oh my gosh, if I could present like her, because if you've seen me present, I'm a little animated and a little spastic, and it can be distracting for people. And Karen is so methodical and calm and pleasant to listen to. You just want to listen to the story all day. And she's known for her teaching, and she's actually traveled so extensively around the state, going to very rural areas, presenting to anyone that will listen to her about child abuse recognition, child abuse prevention, child abuse diagnosis. And she was always asking for opportunities to do outreach. And that was really important to us as a program. But one of my favorite things about Karen is during our case conferences every week, we would be talking about a case and we would say, well, who's the primary care doc or who sent us this child? And we would say a name, and Karen, without fail, would say, oh, he was my intern. Oh, she was my medical student. So pretty much everybody in the state, I think, has worked with Karen at some point, and her contribution to the education of providers in this state and around the country is something that needs to be recognized. So that's why we chose a Grand Rounds as a way to recognize her. So this is for Karen, and we will be doing this again next year. Now, for our speaker, as many of you have been fully aware, we have just rolled out iCentra, and those of us in the child abuse program here have been watching with great interest what's been going on in Pittsburgh because they're a Cerner institution. So the child abuse community is small, we all know each other, and Dr. Berger is somebody that we have worked with for many, many years in different capacities. Dr. Berger is a professor of pediatrics and clinical and translational medicine at the University of Pittsburgh and chief of the Division of Child Advocacy at Children's Hospital of Pittsburgh and the director of child abuse research at the Safar Center for Resuscitation Research at the University of Pittsburgh. Importantly, she served on the task force for child protection in Pennsylvania. I don't know if you heard, they had a little issue there. And as the research lead for the National Commission to Eliminate Child Abuse and Neglect Fatalities. Her specific clinical interests focus on improving identification and evaluation of suspected physical abuse, including the use of serum biomarkers and the electronic health record. She has received funding from multiple sources, including NIH, PCORI, and Hillman Foundation. So when we have been watching with great interest what's been going on with the electronic medical record and improving the recognition and diagnosis of child abuse, it seemed particularly apropos that we choose that as our first speaker for this lecture. So we appreciate Dr. Berger joining us. Thank you.
Oh, that's not the first slide. Let's go back. There we go. Thank you, Tony, and thank you for having me here. This is a real honor to be the first person to speak in honor of Karen. So today I'm going to talk about using electronic health record-based child abuse clinical decision support system to improve outcomes in children at risk for abuse. So in terms of objectives, I'm going to talk about the steps we need to protect kids from repeated abuse and what components need to be part of a child abuse clinical decision support system that is designed to do this. So child abuse, and I know I'm preaching to the converted because you showed up this morning, but I think we all know that child abuse is a big problem. There's about 700,000 kids substantiated as victims of child maltreatment. We all know the number is much higher than that. That's a rate of almost 1 per 100 children in the US per year. I think one of the big issues is the number of children that die from child maltreatment. Over the past 10 years, more than 20,000 children have died. Half of these children are under a year. There is really no disease that we see in the ICU or anywhere else that causes that level of mortality in today's world. And part of that is a testament to immunizations, to car seats, to all the other things that we've done to protect children. But it's also a testament to really how many children this is. And I would argue that there's no other disease where we would allow this many children to die without calling this a national health crisis, without calling this an epidemic, but we haven't done that with child abuse. We have one of the highest mortality rates from child maltreatment. So when I talk about maltreatment, I'm talking about there's multiple kinds of maltreatment. Physical abuse, all these other ones, sexual abuse, emotional abuse, all neglect, different kinds of neglect, and medical child abuse. In terms of what we're doing in terms of child abuse clinical decision support, we're really focused on physical abuse and to a lesser extent neglect and more medical neglect and supervisory neglect. It's not that all these other ones don't happen. Sexual abuse we haven't focused on because 90% of the time families come in and say, I am worried about sexual abuse. So you don't need a clinical decision support system to tell you you're worried about it. So we've focused more on physical abuse and certain kinds of neglect. Physical abuse in particular, even though it makes up 18% of all child maltreatment, it is related to many of the deaths, and that's one of the reasons that we focused on it. If you haven't read this article, this is taken from the Miami Herald. It was an article which won the Pulitzer. It was published in 2014 called Innocence Lost, and the article started with the pictures of 400 children who had died from child abuse that kind of had been covered up by the Florida CPS system. And I said it is a fantastic article, but I think you look at these faces and it's really hard not to realize that we have to do something. I said, this is just Florida, and it was just over the last decade in Florida, the number of children that had died, and there are various issues. They were known to child protection, they hadn't been protected, issues like that. So it's definitely a good read. So why is this a good issue for us in medicine? Well, part of the issue in medicine, particularly as it relates to physical abuse, is there's lots of studies that show that we don't consistently evaluate for abuse, even in situations that are objectively high risk. We know that these disparities and the differences in the variability is persistent. There have been articles over 15, 20 years, and they're very pervasive. And a lot of the disparities are based on race and socioeconomic status. I think one of the first articles was Wendy Lane's article in 2002, which was in JAMA, Racial Differences in Evaluation of Pediatric Fractures. And really what they showed here is that we filed the reports of suspected abuse were filed in 22% of white children and 52% of minority children. And if you look adjusted for insurance status, independent determination of whether it was abuse, appropriateness of performing a skeletal survey, children who were African American were far more likely to get skeletal surveys than white children with exactly the same injuries. In 2010, so now we're 8 years later, Joanne Wood and her colleagues used the Pediatric Health Information System to look at disparities in evaluation and diagnosis of infants with traumatic brain injury. Again, very similar findings. If you're publicly insured, you're way more likely to have a skeletal survey than if you're privately insured, even though you're the same age and you have exactly the same injury. But one of the most important, I think, issues out of this was although the skeletal surveys were done in a smaller percent of white children, once you did that skeletal survey, the chance of your diagnosing abuse was actually higher. So that, which implies that we were that we were underperforming skeletal surveys in the white children rather than overperforming skeletal surveys in African American children. And this is not the only article to suggest this, that this is not an issue of overdoing the skeletal surveys in African Americans, but rather underdoing skeletal surveys in Caucasian children. So we know that many kids who are die or injured from child abuse have been seen by physicians for injuries that in hindsight are likely caused by abuse, but we don't miss the diagnosis. The problem with child abuse is if you send an injured child back to a violent environment, they are likely to get re-injured. It's very similar to domestic violence. There may be a little bit of a lull, but at some point the violence will increase again and they come back and often the injuries are more severe. So what do we need to do? And I think one of the things that perhaps over the years, at least I hadn't really thought too much about, like, okay, we're just going to get people to recognize more abuse. Actually, changing outcome takes a lot of different steps. And if you kind of lose any single one of these steps, you're not going to protect children. So we obviously have to identify that we're worried about child abuse. That's identify. We have to properly evaluate the suspicion, what tests we need to do. Then we have to provide the Child Protective Services worker with documentation of what we're worried about. And this we refer to as the handoff. I think this is probably the most understudied and probably one of the most important issues in protecting children. And this is not what our child abuse clinical decision support does. We have been doing some of the work, what I'm going to talk about, in some of our adult hospitals. But I think part of the problem in medicine, the handoff is a critical thing. And we spend so much time and there's so much research. How do I hand off to the next shift? How do I make sure that the information the people after me are getting when I go home? But no one has really looked that much at how do we give information to a child protective services worker with no background in medicine really, so that they understand what our concerns are so they can appropriately respond. And all these things need to happen in order to protect children. And it has to be multidisciplinary. So it makes it very complicated. And so I would never say that our child abuse clinical decision support system is going to solve all these problems, but at least it's going to try to address them as much as we can. But we have to understand this is a very complicated web of multiple people needing to talk to each other, and not one of these steps can be missed. So what are the barriers? Some of the barriers are lack of knowledge, right? We actually have the data. We know which injuries should raise concern. We have guidelines for evaluation, and we all know clinical guidelines are not enough. But another issue we have is child abuse is rare for any given physician other than, of course, child abuse physicians. It's not as rare as pediatric cancer, but it's much rarer than most of what we see in the ER. So any disease that's rare, it's always a difficult disease to have to identify because you have to put it in the back of your head, this could be a possibility. And I think the other thing is the field of child abuse, as I'm going to talk about a little bit, has really changed in the last 10 years, and it's not something that most physicians are getting ongoing CME. So there are many, many times we'll get reports from our outside hospitals. They'll report spiral femur fractures in 4-year-olds because spiral femur fractures are always due to abuse. And you're like, well, maybe 25 years ago we thought that, but now we recognize that outside of the infant period, once you can walk, spiral femur fractures are actually generally not abuse. They're actually a fairly low energy fracture. But we have people writing things on reports to Child Protective Services. Well, yes, it happened in a public place, but spiral fractures are always abuse, right? And so you realize that the knowledge base that people are working with is what they learned in medical school potentially 30 years ago. I think one of the fundamental issues is it's hard for people to believe that adults hurt children, especially their own children, especially young children. And we're taught to believe families. We take histories, we're taught to listen, everything is in the history. But child abuse is the opposite, where the history is either purposely deceptive or just wrong because the person who's giving to you doesn't actually know what happened. But I think getting over this barrier is the hardest one of all. People do not want to believe that people abuse their children, and they think that they can pick out the abuser from an audience. Oh, I know that person is an abuser. They can somehow see it. And so I think that's a really important barrier. We don't want to hurt people as physicians. We all know that filing a report with Child Protective Services starts a painful process. We do it because we know that or hope that children are better off on the other end, but physicians often don't want to be that bad guy. And we also admit it's a time sink. EDs are busy, child abuse cases take a long time, they sit on the board because nobody wants to take them. We don't always have time to get the detailed history we want in an ER, and reporting can be time consuming. We might have to testify, all these other issues, and I'm sure there's other things. So there's a lot of barriers to actually doing what we want in terms of protecting children. But I think there is some potential of the electronic health record. There is a lot of research about the electronic health record and basically any disease you can think of in terms of screening, evaluation, and outcome prediction. And most of the studies show that the EHR will help with screening, evaluation, and outcome prediction. So there is a lot of basis for why the EHR might be a good place to look. So our question was, could we use the EHR specifically in child abuse? So we started with a tertiary care children's hospital, which is Children's Hospital of Pittsburgh. And we focused initially on how do we identify suspicion of child maltreatment. And like you, we're a pediatric hospital. We have 400 residents rotate through our ED every year. Most of those are not pediatric residents. So the frontline people seeing our children are mostly adult ED residents, family practice residents, and people who are not primarily pediatrics. So we really thought that this was an important place to start. So this paper was published in the Journal of American Medical Informatics Association a couple months ago, and this is about our development of our electronic medical records-based alert system. The focus of this was on physical abuse in children less than 2. We picked this group, as I said, because it's easily missed, there's lots of data, and we didn't, in all of this, we did not want any discussion about were the guidelines, standard guidelines, was the evidence base not there. So we picked this very narrow group of child abuse where there really wasn't going to be any disagreement about whether this was a group we should target. And we know they're evaluated by medical professionals. Most children with young children with injuries will get evaluated. Highest rate of physical abuse, highest morbidity and mortality, they're pre-verbal, and probably most important for an EHR-based screen, injuries and symptoms are most specific. So a bruise in a 6-month-old is highly specific for abuse. A bruise in a 2-year-old couldn't be used as a trigger because most of them aren't abuse. So within that young age group, you can get triggers which are highly concerning for abuse. So our triggers occur in our pre-arrival documentation. So if a child is being transferred in, there's a pre-arrival form that gets filled in. There's one question which says, has a child line, which is our report to Child Protective Services, been filed? Is there concern for abuse or neglect? And it's a mandatory question. So we know when kids are being flown in, whether or not there's already been a concern and whether a report has been filed. Nursing form, nursing documentation, there are many discrete fields. The physical exam, for example, is discrete. You can check on the skin exam if there's a bruise. You can check if there's petechiae. You can check lots of different things which are discrete fields. Orders themselves can be triggers, and the discharge diagnoses can be triggers. So a chief complaint of a fracture in an infant is a trigger because you should be worried about abuse if the chief complaint is a fracture. And we have many kids who come in from places with x-rays, so they already know it's a fracture. An x-ray order, not chest or abdomen, followed by an order for a sedation medication is a trigger because if you first order an x-ray of the leg and then you're sedating them, you probably have a fracture, right? So there's lots of these combinations and everything is linked to age. And so there's a total of about 30 triggers. It's more if you consider it's like bruise or subconjunctival hemorrhage but we counted them as 30 different groups of triggers. And really none of these are specific in 2 or 3-year-olds. You really had to get under the age of 2 for this. So what we did was we ran our system what's called silent mode. So the research team could see every child that would have produced an alert for the physician when it were live, but it wasn't live. So we could see it in the background, and we did that for 5 months. It allowed us to refine the triggers. It allowed us to correct coding errors. So for example, in terms of refinement of triggers, we had blunt head trauma in a child less than 6 months as a trigger because we thought, if you're under 6 months, you have blunt head trauma, that's what we're worried about abuse. Turns out our nurses used it for like every single infant. So it would have been a huge over trigger, so we had to get rid of it. We accidentally had said all x-rays followed by sedation medications, and all of a sudden we realized every kid who gets intubated was triggering, so we had to get rid of chest x-ray combined with sedation medication. So we had to fix things like that. And then coding errors. We had coded all of this from scratch. And so, for example, there was an or where there should have been an and. So if a nurse checked bruising and rash, it didn't trigger, right? Because we had coded it wrong. So that 5 months kind of allowed us to fix those issues. It allowed us to calculate the sensitivity and specificity of the alert system. And then we wanted to also calculate the baseline compliance of our hospital with the American Academy of Pediatrics guidelines for screening, so we would know when we did the next step, which is a randomized controlled trial, whether we had done anything. So we kind of use this silent mode to do all of these different things. So if you look at the children who triggered our alert system, so there were 226 kids who triggered. It's about 0.6% of the children in our ER, and it's remarkable how consistent it is. We've actually been, as I'll mention, it's been live as part of clinical care for about a year and a half since the end of 2 years, the end of 2015. It's amazing how consistently the percent of kids who trigger is. So if you look, there's no difference in the gender of the children who trigger. There's no difference in the race of the children who trigger. There's a very significant difference in the public insurance. So the children who triggered, 77% of public insurance compared to 62% of the kids of that same age group seen in our ER in that year. So as a set of proportions, it's about 0.6% of all kids in our ER. And this has been consistent. It was consistent in the randomized controlled trial as well. So how did we decide what the sensitivity and specificity was? So we had to define our reference standard, which we determined to be if the child protection team decided something was possible, probable, or definite physical abuse, it counted as a case. If the child protection team said it wasn't abuse or they didn't see the child, it was not abuse. So we had 62 kids who had a diagnosis of possible, probable, or definite physical abuse under the age of 2 during this silent mode period. 60 of those fired, 2 of them did not. The 2 cases that did not fire, one was a child who went from the ER virtually directly to the ICU, so there were no orders placed in the ER, so there was no opportunity to trigger. I would hope that child would not be missed as a child abuse case because they went directly to the PICU. The other one actually was a child who came in for failure to thrive, and when they got to the floor, there was concern about the etiology of the failure to thrive, and somebody got a skeletal survey which showed old fractures. But in the ER, the concern was not physical abuse, it was failure to thrive, so there was no opportunity for that child to trigger. But here's the big problem. How do you decide, of the children who didn't trigger, we had 166 who triggered. So they popped up even though in the end we didn't decide they were abuse. Of those 166 cases, 45 of them, it was totally unreasonable that we should be worried about abuse. It was an over trigger. There were things, for example, where the nurse had checked the chief complaint was assault, but they really meant asthma because they're one after another. They realized that they changed it, but the doctor's already gotten the pop-up. So in certain cases, it was just unreasonable that they would be worried. But in most of these cases, it was actually very reasonable that a doctor was worried. It's just that it turned out not to be abuse. So the doctors did not at all feel that these were over triggers. In fact, I would have liked actually more over triggers because it would have made me feel like I was picking up more kids. So we thought this was reasonable. The big question was we had 10,710 kids who did not trigger and did not get a diagnosis of abuse. And the question is, how many cases of abuse are hidden in this 10,710 children? So we were trying to figure out what's the best way to figure that out. So we either could have we can't look at 10,710 charts. We could have randomly selected charts and said, did there any missed cases? But actually we did what I thought was probably a better idea. We took a non-random selection of the 10,710 insofar as we looked at every case that the child protection team had seen in the subsequent year and went back and looked to see if those kids were in that cohort of 10,710. Because if there's any group in that group that's the highest risk of being missed, it's ones we saw the next year. So we went back and looked at those children. And there were 210 kids that we evaluated the following year for any reason. 40 of them actually did have visits. They were part of that cohort of 10,000. And they had a total of 61 visits during that silent mode period. So we obviously reviewed all 61 visits to see were those potentially cases of missed abuse. So 59 of the 61 visits were totally unrelated to trauma. There was clearly no concern of abuse. There were 2 that we looked more closely at. There was a 6-month-old who came in with a closed head injury and a single bruise to the forehead who was discharged during silent mode. And then actually was referred to the child protection team for a tooth injury at 10 months of age. The child protection team did not think it was abuse. It was not reported to Child Protective Services. So probably that 6-month-old with a single bruise to the bony prominence was probably not a missed opportunity. Patient 2 is a 9-month-old for routine physical exam prior to foster care placement. The physician note, which is free text and you can't use that to trigger, said there was a dime-sized brownish bruise on the left upper calf. They did not feel like there was concern for abuse. It was actually a mobile 9-month-old. And actually we saw the child for medical neglect 2 months later had actually been returned to the parent between those 2 times. So I don't think that was a missed opportunity either. So I think that made us feel better. Of course, there could be children in that 10,710 said that we didn't see in the next year. We also know that none of those children died because we also got the list of all the child fatalities in the county. So we decided, at least on this, the system's accurate enough that we're going to move on to our randomized controlled trial. And this was really to see whether it's improved compliance with our guidelines. The randomization had to occur at the level of the patient, which is a really important issue. We would have liked to do it at the level of provider. The problem is you have to randomize the child as soon as they get to the ER because the pre-arrival form is a trigger and that links to the patient before a physician is even signed up to see the child. And when they open the chart, you need to have it trigger if it's already, you need to have it alert. So we had to do it at the level of the patient. And it was based on their FIN number, a random, even were cases and odds were controls. But we knew at the beginning that this had the potential for group contamination because a physician could see a child at the beginning of their shift who triggered and a child later in their shift with the same injury who did not trigger. right? And so, but there was no other way to do it. You could have done it with another hospital, but I'm going to talk about actually moving this to another hospital is really hard, and you deal with your own problems then. So we really didn't feel like we had another option, but we recognized this was a problem, potentially. So these were the AAP guidelines that we were looking at. As I said, we purposely did things we thought were not controversial. So a non-cruising infant with a fracture had to get a skeletal survey, CBC, platelets, PT, PTT, and liver function tests. We did not require calcium, magnesium, phosphorus, or alkaline phosphatase. We only required the bold one. So less than 6 months with a bruise, you had to get skeletal survey, neuroimaging, CBC platelets, PT, PTT, liver function tests. So this was our requirements for each of these scenarios. So then we have a trigger system that alerts the physician. So how do we alert them to do the proper evaluation once they have a child who's been identified? So we set up a system. When it's live, this is what happens, and I'm going to show you each of these steps. So a patient sets up the alert system either when the doctor opens the chart the first time, when the doctor places any order in the chart, or it can actually alert after discharge. So if a doctor never opens, so we have something in Cerner called PNED, where you can kind of write a note, but you're never actually opening Cerner, and so you can't get alerts. So it's possible that a physician sees a patient, documents later, they never open the chart, but at some point they have a discharge diagnosis, and that actually alerts it after the child is gone. So we have a system set up. We have an ED physician who reviews every single discharge alert every day. It's about 2.7, 2.3% of the triggers, and they make sure we don't have to bring those kids back, because we were very worried if you alert a child and then nobody knows about it, that's a huge problem. So we have a system set up for these discharge ones. So as soon as the alert goes off, there's a positive physical abuse screen in the chart. The nurse gets an order to completely undress the patient and to measure the head circumference, because we're going to want the head circumference when we're deciding whether we need neuroimaging in a 6 to 12-month-old. We were trying to get them to do it routinely, at least in the young kids. But when they do that, they get this order. The positive physical abuse screen is actually really important, because anytime you open that child's chart, you'll see that they had a positive physical abuse screen. And then they get a light bulb on their tracking board. This is important because the UPMC hospital system made this the alert for child abuse. So in every single hospital in the UPMC system, when your child abuse alert goes off, and the adults have a different system than we do, which I'm going to talk about, they all get the bulb, which is important because the residents are moving from hospital to hospital. So they know that this is the child abuse sign. Then the physician gets a pop-up which says nursing or physician documentation suggests the patient is at risk for physical abuse. Remember to undress the child, look in the mouth, review CCHIE is our exchange for prior concerning visits and plot head circumference. Do you want to see the physical abuse power plan? I will say this is my least favorite alert. There were like 5 choices, but our ED docs wanted this one. So I like the one with the least number of words. They wanted the one with the most number of words. So that's what we have. And then do you want to see the physical abuse power plan? You can press yes, and I'll show you what happens. If you press not now, when you reopen the chart, you get the same trigger, so you can access the power plan. And if you say no, never, you have to say why you don't want to use it. So say you say yes, you get your physical abuse power plan. We set this up as a power plan with multiple subphases. So each subphase, for example, bruise or petechiae in a child who's not yet cruising, fracture in a child who's not yet cruising, intracranial hemorrhage who's not yet cruising, you click on what you want. I will say the bruise, petechiae, burn, and subconjunctival hemorrhage in a child who's not yet cruising, they're all exactly the same list, but Cerner puts a 42-character limit on the name of your subphase. So we had to make different subphases because of Cerner's intricacies. So say you want to do one of these, you click what you want, and you get a list of orders. So everything which is required by the American Academy of Pediatrics or by our trauma service. We didn't want people to have to do a power plan for trauma and a power plan for us, so we merged together what our trauma team wants, so there's only a single power plan. Everything there is pre-checked, and then anything that is dependent on another test is not pre-checked, and it has a note. So abdominal CT is recommended only if AST or ALT is greater than 80. This is in a child with intracranial hemorrhage. So everything recommended by the AAP is pre-checked, and everything else has a note. Physicians can, during the randomized control trial, the IRB required that physicians could search for the power plan in the order catalog even if they didn't get an alert, because people thought it was unethical to only be allowed to use this power plan and order the correct things if you got the pop-up. We absolutely agree with the IRB, but as I'll show you, this turned out to be a very interesting issue. Okay, so what happened in our randomized control trial? This is a very busy slide, but I'm going to focus you on 2 things. This article, I think, is going to be next month in the Journal of the American Medical Informatics Association. So over the 7-month period, we did the randomized control trial. 306 kids triggered, which is almost the identical rate as in the silent mode. Half were obviously cases, half were controls. The number in which they were considered to be over triggers was basically the same. But in the end, we had 85 kids in the case group who met one of these AAP clinical scenarios. In 12 of them, what we call clinical judgment made evaluation unnecessary, and we defined that very clearly. A publicly witnessed event, a child with a known underlying disease that was related to it. So they were very specific because the trigger system wouldn't know if something occurred in a public place, right? But then it's reasonable to say, I don't need it. We had one infant, for example, with hemophilia who came in with a bruise, who, the PTT was 100 or something. So that child, it was reasonable not to do a child abuse workup because there was a known underlying problem. So we had 73 kids in our case group who met the scenario. They needed an evaluation. 67 or 92% of them were fully or partially compliant. That is really, really great. It's really high. This is terrific. However, if you look at our control group, it was almost as high. So we're like, how? That's not really good. So what happened? Well, it turns out we had assumed a baseline compliance rate of 70%, because if you looked at the Pediatric Health Information System, they had compared multiple different hospitals, and the top third was about 70%. And we thought, you know what, I think we're pretty good at this. So we said, how can we get from 70% to 90% with this system? And we calculated our sample size based on that. We didn't know our compliance before we started the RCT because you had to go straight from silent mode into the RCT. So we were calculating it during the randomized control trial. And it turned out that baseline was 87%. So I was like, wait a second. So we went back, and it turned out that Children's Hospital Pittsburgh was by far the top performing site in the Pediatric Health Information System, which we had no way to know before we started. So it's great for Children's Hospital Pittsburgh, but we weren't able to show that this did anything in our hospital. So there is no way we could have kept the study going to show any difference, right? So the sample size would have been well over 400. But the other thing that happened during this time was the use of the power plan increased significantly. So we had 43 patient encounters that used this power plan, and there's actually no difference in use between the cases and controls, because once physicians knew it existed, they all used it. And even now, we almost never have a skeletal survey not ordered from a power plan, right? So it became one of the big problems with clinical decision support is people don't want to use it. And actually, that is our problem in our adult hospitals. Nobody wants to use the power plans. So we kind of anticipated that people wouldn't want to use them. We'd have to keep educating. We basically did nothing, and people love them and they use them. So again, it's a good problem from a clinical perspective, a very difficult problem from a research perspective, because everybody was using the power plans. So there was no difference between the two groups. We did, when we looked at the partially compliant, so say you did everything but LFTs, or say you did everything but something else, we did decrease the partial compliance to almost zero. And if you use the power plan, everybody is compliant. So it does that. In our case, it actually helps as well. In every case the power plan used, the provider is fully compliant. So it helps in that way. There were also some other positive outcomes which are harder to measure. One, it was very clear that the outside residents who may never have thought about abuse before had thought about it and were precepting with attendings and had thought about it before they even talked to them. And that's actually a really good learning tool, but we were looking at the attendings as the person who was compliant because there's just too many residents. The other issue is we very rarely have to do second blood draws on the floor anymore, because when they get the power plan, for example, they're getting a vitamin D and a PTH, for example, in the infants with fractures. So basically the next morning we come see them, we have our values, they don't get restuck, and they go home. So it also has greatly decreased our second blood draws on the floor because they just get everything in the ER. So we weren't looking at those, but I think they're positive outcomes. So I said we had high baseline compliance, we had all this group contamination, and everybody loved the power plan. So we really need to see how this works in a hospital with lower baseline compliance. And actually last month, I'm going to show you in Pediatrics, somebody published this data. I said we had very positive end user feedback. I said eliminates the need for a second blood draw, and we've had it in clinical practice since 2015. So our current residents don't remember before we had this. And this is just the way it has been at Children. So I don't think we can study much more. We're still constantly making tweaks to it. We do checks of this about every 3 months. We get a download of all the kids who triggered in the last month. We make sure the system is working, because whenever you do an upgrade, I'm sure it's going to be the same thing with yours, things change. And the system has crashed twice since we started it. The first was at the very beginning, and the last was a couple months ago, 6 weeks ago, and it was identical in both cases. Someone who did maintenance on the server that ran this clinical decision support system and didn't tell anybody. And if you turn off the server and somebody gets an alert and they try to press it, the whole cerner crashes. So it was the same thing both times, and it was amazing. I woke up, it was about 6 weeks ago in the morning, and I had 6 emails from people saying, I tried to get the power plan and the system crashed. And so it was up within the next day. But you just have to be so on top of it, because when people change things or change the way an order is written, now the power plan is no longer ordering that order. So somebody may change an order for the way someone's ordering a CPK or some other test you use. They may change the actual order, and you have the old order in your power plan. If you don't notice that, it doesn't order that test anymore. So you do really have to stay on top of it, even once it's part of clinical care. So Cincinnati Children's, which is Epic, looked at kind of, I guess, another kind of clinical decision support. They only looked at children where there was documented concern for abuse. So they skipped that first step of identify suspicion. They only looked at evaluation of abuse. But it's the only one that's out there other than our system. So I thought it was a good way to look, to see how this worked. So they constructed a best practice guideline. I will tell you it's basically identical to the one we had. They also added a troponin, which I think is standard there because there's research done in their center, but it's not standard other places. They did provider education, they had a guideline, and they had an order set. So very similar to ours in terms of the intervention. So they track compliance, same guidelines. They had 640 kids in this 2-year period. Their baseline compliance was 47%. And that was only in cases where they were already worried about abuse, okay? And they increased to 69%. So they said, okay, at least having an alert and an order set appeared to increase compliance. I thought it was really interesting. I started thinking about this because they missed the whole step of how do we identify kids with child abuse. So we had 306 kids less than 2 trigger in the 7 months. So we had 268, which were considered not over triggers. That's 38 a month of kids who are triggering. They had 640 kids, less than 3, they went further up in age, in 27 months. So that's 24 per month, right? So they're triggering about, significantly fewer, and their ED sees many more patients than we do. So if you actually look at the volume, you would have expected them to see about 45 cases a month, right? If their trigger system had identified the same number of cases at our trigger system, they would have had twice as many, which is really concerning because their compliance rate was still really low. And that's only the kids where people identified abuse. And there's about 50% more where nobody thought about abuse. So at least when I started thinking about it, I said, gosh, I think they really need that first part, right? How do we trigger the kids? So there are many kids there who should be getting an abuse evaluation who aren't, because they're only looking at kids where you're already worried about child abuse. The 2 to 3 years, I think it's a mixed bag, because over 2 years of age, you don't really need to get a skeletal survey. The American Academy of Pediatrics does not require it. There's not really a required evaluation. It's really based on what the provider thinks is best. Between 2 and 5 is at the discretion of the provider. So I thought it was a little strange that they put that older age group, because there really isn't much you have to do in that age group. So the next thing we tried to do is, can we do a similar system in our 13 general EDs? So our whole hospital system is Cerner, but they are 2 completely different platforms. And the reason is that the Children's Hospital of Pittsburgh was bought by UPMC the year the EMR went out, which was 2009. So we were one of the first electronic children's hospital, but we were purchased when we already had Cerner live. And so the rest of the hospital system already had a different platform of Cerner. So all of those hospitals have the same, and we have a different platform, which means you have to develop a completely different alert system because there's nothing similar between the 2 systems. Even the orders aren't called the same things. So, but I really thought this was a very important part of this project, because we know that most kids in the US get emergency care in general EDs. They're not in our pediatric EDs. The rate of proper recognition of abuse is lower in general EDs. So more kids are being seen there and more kids are being missed. Abusive fractures, as one study showed, 7 times more likely to be missed in a general ED. So you could have argued we should have started with the general EDs, but given all the problems I'm going to show you that we had in the general EDs, I'm actually glad that we started in a pediatric hospital and kind of worked out some of the issues before we went into these general hospitals. So if you go back to this, what do we need to do to protect children? We tried to kind of redo this on the adult side. So in terms of identification, they have no discrete fields there. They use charting by exception. So basically, if something's abnormal, they write it out or type it out. So there's no discrete fields to click on. There's no pediatric forms. So you can't click on they don't have a pre-arrival. And generally, nobody's arriving there, right, because they're not being transported. So basically, all the triggers that we had, we could not use. So we had to find something else. So we developed 2 ways to identify at-risk kids. A child abuse screening tool, which I'm going to talk about, and then I'm going to talk about a rule-driven trigger system. The child abuse screen is basically to recognize red flags in the evaluation. And we took the ESCAPE screen from the Netherlands, which is the most validated of all the child abuse screens, and we had to tweak it for use in the United States because the Netherlands does not have mandated reporting. And basically, if their screen were positive, we would be mandated reporters, and that's not a screen. So we work with the legal department. We made some changes. Some of the language was really strange, so that when you translated it from Dutch into English, sometimes the yes was a positive, sometimes the no was a positive. So we made changes, but we decided they weren't significant enough that we had to revalidate it, but they were for use basically in English. We integrated into the electronic health record, and we made it so that a positive did not require mandated reporting under pretty much any state law. The primary nurse fills out the 5 questions. It's mandatory, but not a hard stop. We only have one hard stop in our EHR, which is a suicide screen that's positive. So the fact that it's mandatory means that the charge nurse gets a list of all the ones that aren't completed at the end of each month, and the nurses have some incentive based on it, but there's no hard stop if they don't do it. And any positive screen, which means any single positive question, triggers a pop-up alert to the APP or physician. The part of what we wanted to do was encourage team dialogue, which is something that we saw being done much less in the general EDs. The doctors didn't know what the nurses were doing, and the nurses didn't know what the doctors. Nurses were filing reports, doctors were filing reports, they weren't talking to each other. So we tried to make this so that people would start talking to each other. So Cerner, maybe your Cerner's better. Our Cerner is stupid, and it can't automatically pop up a screen for a child less than 13 years of age. So you have to answer the question, is a child less than 13 years of age? And it puts the age for you right there. So this is what's ridiculous is the number one reason screens aren't filled out is they check as a child less than 13, no, when the child is less than 13, which shows, I'm not even sure the nurses read some of these sometimes, but we had to have that question first. Maybe your system is better. And then the child abuse screen pops up. These are the 5 questions. The first one is about delay in seeking care. The second is the history not being consistent. The third are physical exam findings. The fourth is poor supervision, care, nourishment, or hygiene, which is the neglect question. And the fifth is any other comments. And we get comments like, parents slapped the child in front of me in the waiting room, or something like that. So they put comments like that into that 5th question. All children less than 4 must be undressed completely. That has, I think, been the most important thing this has brought about because the nurses are undressing kids and seeing things they would have never seen when the kids were completely dressed. So we evaluated this over a 6-month period. I will say we actually had a 2-month evaluation in 2 of the hospitals first, and we had to tweak a couple things. And then we had to train all 550 nurses in the UPMC system, which we did through what we call ULearn. Some people call it iLearn. It's a program that every nurse had to take this program, or this 1-hour training. So what we saw when we looked at this, there were 17,000 children seen in one of these EDs during the 6-month period. 11,600 were screened, which is 68%. If you look at other screens, this is actually right on par, and it doesn't have to do with the child abuse screen. If the nurse filled out the triage form at all, they did the screen. The ones that weren't filled out are nurses that don't fill out any screens. They just don't do anything at all. So that's a broader issue than just, this wasn't an issue that they weren't filling out this child abuse screen and filling out everything else. They just were filling out nothing. And then we had 146 reports to CPS among the people that were screened, so 1.3%. There were 5,000 kids not screened. There were almost no reports on those kids, so 0.4% of those kids. So the problem is we couldn't look at how many reports were filed before because the system had no way to document that any report had been filed with Child Protective Services, which was actually a huge medical legal issue, particularly in Pennsylvania after Sandusky. There was no way to say, hey, we reported this. Sometimes a doctor would write in their note, sometimes a nurse would write it, sometimes a social worker would write it, but it was all in free text. So as part of the system, we developed a way to actually tell if you reported, so we couldn't compare to a pre. The only thing we could do is compare kids who were screened from kids who were not screened. And I'm not going to go into too much detail, but we do in the paper, there doesn't appear to be any difference between the kids who were screened and kids who were not screened, except that the nurses who didn't fill out any triage forms didn't fill out this form. If you look at the positives, about 50% of the positives led to a child abuse report. So it wasn't that every time you had a positive, they were actually reporting it. This has actually been part of our clinical practice since the end of 2016. So as soon as the study finished, the evaluation finished, it has been part of clinical practice. So we've had well over 100,000 screens done. So we thought that at least was a start. We were identifying kids, they were making reports, and if they weren't screening, they weren't making reports. So it seemed like that was better. The feedback from the nurses was overwhelmingly positive. People clearly felt that they were identifying things they had never reported. These nurses were calling us because they didn't even know how to report because they had never done it before. So that's all subjective, but it did seem to make a difference. But then the other question is, can we do something else? So we developed a very simple natural language processing system, which called rule-given trigger system, in 2 of the EDs just to test it. So we tried to basically take it's called FAC, the Focused Assessment Chief Complaint, and develop some rules. So if certain words occurred there, combined with certain ages, that would create alerts. And certain discharge diagnoses, certain orders. For example, they do so few x-rays in young children that if you did an x-ray of a leg, for example, in a child under 9 months, that was a trigger, because at least you were probably thinking about a fracture. So the other thing it was more of a belt and bootstraps kind of thing. If the child abuse screen isn't done or it's not done correctly, this can pick up some of those kids that are missed. And that actually turned out to be the case. So what were the ones? And you have this handout, but basically any of the following words in the chief complaint or focused assessment, a kid less than 12 months, assault, abuse, bruise, or any part of the word bruise, burn, not moving, fracture, FX, broke, injury, sprain, deformity, all these different things less than a year of age. However, if it's preceded by the word deny, no, not, all these different things, then it doesn't trigger. And a lot of this took a long time to figure out. For example, broke. We have someone trigger because the father spoke broken English. The child was 4 months of age. We had a Dr. Burns in our system who was triggering on all their kids. So there are all these different things that you can't, tetralogy of Fallot has the word fall in it, right? So we have kind of over time, every 3 months, we're allowed to kind of update it and we tweak it, and it's actually gotten much, much better. This is very simple natural language processing, but it actually works quite well, particularly when people don't do the screen, like if they don't do their child abuse screen. So it is a nice addition. It went into all of our hospitals actually February 21st as part of their clinical care. So it was the rule-driven system actually is the trigger now about 30% of the time. But most of the time it's because the child abuse screen isn't done. If the child abuse screen is done correctly, most of the time it should pick it up. The over trigger rate's about 25%, and mostly it's just these weird, things in English. It's hard to fix. And we're still looking at some of the data analysis. I said, and every 3 months or so, we tweak the wording and kind of fix things that trigger that we wouldn't have expected. So that's what's identifying. So that's that first box, how we're identifying abuse. Now, how do we evaluate it? So they get a pop-up alert, just like in the other hospitals. And we say fully undress them, review the nurse screen, and why don't you use a physical abuse power plan? Their platform does not allow this not now, no, never, or yes. They can only say continue. They have to search for their ED physical abuse power plan, another difference in the platform of Cerner. This is their power plan. They get it's under ED cardiac power plan, it's under ED physical abuse power plan, and they have the same idea, subphases. The subphase is meant to be used for children not yet cruising or present with a bruise, petechiae, subconjunctival hemorrhage, burn, or frenulum tear, because they can have a longer code. Their power plan, we wrote them with their ED directors, and they are focused on when to transfer, when to file, and when you don't need to do tests before you transfer. So very, very different than ours, because we're admitting our kids. Nobody's getting a vitamin D level in a child with a fracture in an outside hospital. In fact, they don't even want to draw any blood. So this is a bruise. It says, consider Childline, complete skeletal surveys, consider transfer to Children's Hospital or Mercy for burns after filing Childline, right? So theirs is focused on the actions as opposed to just doing labs. And we did this, as I said, with their ED directors. Some of the things I didn't totally agree with for some of the subtypes, but the more important thing was that they had the buy-in from their physicians. So in terms of how compliant they were, at their baseline, so this is exactly what I think happened in the Riney study. So we have no way to know how many kids we were not identifying before, right? Because once we have a system, we saw, well, in the baseline data, we had 11 kids over 7.5 months who the child abuse were triggered, that we thought were potential child abuse cases. They seemed to be 64% compliant. We were like, wow, that's great. But now look at the live data, which is almost the same amount of time. Now they had 44 cases in the same amount of time. Well, we had the child abuse screen that was live now, right? It hadn't been live before, because part of the problem with this is the IT people, when they go live and when you're ready to start doing stuff, is not always the same, right? So we would have liked to start our baseline, for example, and start, for example, the live data right when the child abuse screen went live. But of course, they were in a build freeze. You couldn't start because it was a freeze, and then there was an error, and then there were also, these didn't line up exactly, right, when the times of different things happened. But our live data, we had the child abuse screen live now for that whole time. And the compliance was now high when the physicians used the power plan, but it appeared to be lower overall. But mostly this was just, now there were more kids, right? So now we were identifying more kids because the child abuse screens were being used and they were positive. And I think if the Riney study were redone, what they would see is their compliance is actually lower because because they got more kids if they start identifying abuse kids. Our post-test in this 7-month period, we had 6-month period, we had 20 kids, and now they appear to be becoming more compliant. The number of order sets is being used is more and more, and the compliance is up when the power plans are used. This is actually, we're now, beginning of 18, they're around, I'd say 70%. So they're gotten better. It's not as good as us. We're really struggling. They don't like to use the power plan. They use a couple a month. They have a lot of turnover of physicians. It's very hard to educate. We have a much more controlled group of attending. So I think we are identifying more kids. They are using the power plans. We're better off than they were, but there's a long way to go on this. The other focus we had in the adult hospitals, which we didn't do in ours, was how do we talk to Child Protective Services, that handoff. And so there's something called abuse reporting. There's a folder. It's called abuse because the goal was to put domestic violence and elder abuse reporting in that same folder. And we decided that we were going to internally document what was basically information given to Child Protective Services, and so that we could track all the reports. So it's called the CARF, our Child Abuse Reporting Form. And this information gets basically copied from here directly into that report to Child Protective Services. And it's a multi-contributive form. So the nurse does the top, the doctor does the statement, and then they copy and paste it into the actual report to Child Protective Services. This is like a screenshot of the form. So we tried to do a couple of things at very different, for each of these steps. There is a long way to go. We have reports to Child Protective Services that say child with injury, and that's what they're telling Child Protective Services. That's really hard. And they're like, well, they didn't do anything. And you're like, well, look what you told them, right? So there's a lot of education to still do, but at least now we can see what they're telling Child Protective Services. Before, without that CARF, we didn't even know what was being said. So at least we now know, we have to start working with some of these statements that are being made. So to end, we have something now called the UPMC Child Abuse Initiative. And this is how we had to transition from all this done on a PCORI grant to clinical care. And we've really tried to focus now on ED empowerment. So this is a 2-year project being funded by Children's Hospital, so it ends the end of 18. Each hospital has a child abuse team led by their sexual abuse nurse examiner, their SANE, who collaborates with their ED director. Every week, each site individually receives a report of all of its child abuse screens, every child seen, whether they had a report, whether it was positive, and they have to review their own reports. We review all the reports to Child Protective Services, and we review all the child abuse screens. We only intervene, like for this example, this week we had a 5-month-old with a cheek bruise where nobody did anything, right? So the child abuse screen identified it, the doctor decided they weren't worried, we intervened, and the child came back yesterday for a skeletal survey. So we intervene when it's something that we feel is not okay that somebody missed, and then we go back to the practitioner, who frankly usually like, well, I'm still not worried, and we just kind of override them for things that we feel are really important. So we send about 6 to 8 emails a week, and we bring back about 1 to 2 kids in the hospital system, which is about over 160-mile radius. It is a lot of work. We keep a list, though, of all the children we unequivocally have made a difference, and it looks like about every 6 months there's 3 to 4 children who probably would be dead had we not intervened, which is a pretty darn big number. And it's very clear. It's like a child who goes on with a bruise, we bring them back and the skeletal survey has 4 fractures, right? And so now we intervene, the child's removed. So these are really, really clear cases. But it shows that we're doing this despite the fact they have an alert system, right? So these kids are alerting and we know about it, but they're not responding correctly, which is why we have to come in and respond. But, I said at least we know about them now and we're responding. We have a conference call of all the sites. We talk about cases. They get their own statistics, and then they see where they are compared to other people. That helps keep the screening rates up. We're working on guideline development. We have one from motor vehicle crash reporting when kids aren't seatbelted. We have now one for ingestion reporting. We do presentations to the site, and the nurses now had to redo their ULearn for the child abuse screen. So now we are trying to expand this. We could go to other children's hospitals which have Cerner. This now includes you. We have a grant from the Beckwith Foundation to do this. There are 12, now 13 with you guys, hospitals with Cerner. And we have a bunch of them already on board getting coding. Everyone is different, but we can provide the code, which makes it a lot easier, and the actual power plans. And we have a grant from PCORI to disseminate implement this in 2 other EHRs. So we have EPIC, which is University of Wisconsin, and Northwell, which is Allscripts. This grant just started in March, so we're just starting at these sites. So I want to thank all these people. We've been very lucky to have a lot of funding from this and incredible support from the UPMC IT team. And our old head of IT, Vivek, is now the new head of IT come here. And he had been very, very supportive of this, as is his whole team. So I've not much time for questions, but one or two, I guess.
Hi. Diego Saludlo, I'm Associate Chief Health Information Officer for Mountain. Question, why limit this to emergency rooms and hospitals?
Why limit it?
Yeah.
As opposed to like urgent care centers and.
Urgent care, primary care,
So
others?
it's a really good question. And actually, so one of the people on our team, Bruce Rosenthal, is a pediatric trained ED doc who now is an adult ED doc who actually is working with our urgent care centers. Our urgent care are epic, even though our EDs are Cerner. And they are doing something in the urgent care centers. The problem is it's just a resource issue, right? And so I think the reality is, yes, we need to go into other places, probably primary care practices too, but the actual triggers are going to be different. The way the documentation is different. The way the power plans are set up is different. And even, for example, our urgent care centers, they can't do a skeletal survey, right? So theirs is focused on when do I transfer? When do I call for advice? So we're working on it, but there's just so many potential places to go. So we start with the ED. Frankly, it's easiest to start in your own ED. You know the people where we see kids, that's why. But I don't disagree. It's just an effort, a resource issue. Good question.
Rachel, the question I have is, what are the unintended consequences, particularly in a system that is vertically integrated?
So do you mean in terms of liability?
For the unanticipated consequences, focus on the number of flags not going out. Long term.
That's a really good question. In fact, I will tell you that we had the head of our risk management team on our stakeholder committee from the very beginning, because we recognize that there's a lot of issues here. I said very beginning, so we were changing the escape tool, for example, so that it didn't mandate reporting when the screen was positive. Some of the issues, for example, is you have a positive screen and a physician doesn't respond to it. What is the liability of the hospital system? It turns out the liability is actually the physician's liability, not the hospital system's liability. The physician has been told, they specifically override it, which we can track. We know everything that happens. So from a medical legal perspective, our people thought, actually, this is very good for us, right? Because we show that we screen, which is, Jaco's looking for that now. We show that we're screening. We show that we're responding. The biggest issues, so last year, for example, we were asked to tell, there was a very high profile case where people claimed we hadn't reported. Literally in 10 seconds, they could show we had a child abuse reporting form and that we had done our mandated reporting duty. So from a legal perspective, they're actually very happy with this because we can document we've reported, right? It even says like who you talked to and what the reference number was. We can document that. We can show that we're screening, which is important. But there is liability to the physician. And we talk about this, part of that you learn is to nurses. If you think it's abuse and the doctor doesn't, you are still a mandated reporter, right? You don't lose it. You cannot sign off mandated reporter duties. So I think that's important to think about some of those issues. We haven't had issues in terms of like families saying, I want you to get rid of that positive physical abuse screen, because they wouldn't, that's not part of something that ever gets given to them. I think part of the question people are being is, well, aren't you going to be evaluating a lot of kids who don't need to be evaluated? And our argument was no, right? We do CTs in a lot of kids who don't have traumatic brain injury, right? You have to have a yield on these skeletal surveys, which is a whole other topic of probably about 5% or so to know you're screening enough kids. We're way above that now, right? The average is about 20, a little over 20% positives. So I think that there are issues, and kind of we recognize these because that's why we had risk management on board the whole time. There have been some pretty darn big lawsuits of physicians and hospitals missing abuse. There are very few lawsuits about physicians reporting, right? Because you're civilly protected under that. So I think if anything, our legal people really feel that this is protective. And we've had a few cases where that's definitely the case. We're having this, we've been able to show that we're actively screening and it's objective. And actually that's a really good thing, right? This triggered based, we can tell you exactly what this triggered on. This wasn't, we've had families complain, for example, like I got a child abuse workup, and we've had some people say, well, why did they get the workup? I said, because they're under 6 months, they had this injury, that triggers they should be worried. And they say, well, how about race? Race isn't part of that trigger system, right? And so it actually being objective like that and having that actually I think is a very good thing. Because you can show people exactly what triggered and why we're concerned. Yeah.
Over time.
I'll make it quick.
I'll ask my question.
Sorry, I'm not good at that.
So so I'm one of our emergency doctors. My perception is that in the pediatric emergency department, we're moderately good at being suspicious. We are low to moderately good at investigating appropriately. We are poor at reporting because of if there's any grayness at all, we're worried about what it's going to do to the family and the family response, as you had mentioned at the beginning, but also recognizing that our system is under-resourced significantly, and if we report if it's not black and white, nothing will happen. We don't get great closed-loop communication, so we never know what happens, so it gives us less of an incentive. How did you overcome that reporting issue?
That's not a short question, but that's a really, really important question. And actually, we were very worried about this. I have to tell you that one of the very interesting things in adult hospitals, they over-report way more than our hospital does. I could not believe some of the reports. Child has a subdural hemorrhage. They're like, why do you report? Well, he has a subdural hemorrhage. Yeah, but it was in a car crash, or it was a fall out a window, or whatever it was. And they're like, yeah, but it's a big injury. Like they were reporting all this stuff, and you'd be like, why did they report? Right? And they're like, I just didn't get a good vibe from the family. Like, what do you want them to do about that? So what we noticed is actually there was a huge amount of over-reporting, but then the kids that were highest risk, they're like, oh, I'm fine with that cheek bruise. So that's actually been a big issue because CPS, you kind of like, well, I kind of feel bad for them because we were trying to get rid of some of the underreporting, which is actually very, very hard, while increasing the correct reporting. I think the issue of what CPS does, that's actually one of the reasons we focus on the very young kids. Because at least in our system, they actually respond very well to the 60s. They don't respond so well to the older kids. So one of the other reasons we focus on that very young kids was that reason. We do a lot of follow-up with Child Protective Services, and I will do chart reviews for them on any kid that triggers here. I actually have a case, it was supposed to be today, but they moved it next week, of a case from one of the counties for one of these kids that triggered, where I opened it up and they actually had 6 prior reports and no one had put them together. We wrote a report, they actually removed the kid. There was a confession, blah, blah, blah. And that Child Protective Service agency now calls us whenever they get reports on children, young children. So actually the relationship with our counties has gotten way better because they're like, did you get this kid on your initiative thing? We have 23 counties around us. So it's actually, I think, just a very long process, but it's not, you know what I'm saying? I think it's gotten better over time. And that's why we focus on the young kids. The older kids are very hard because I agree. They don't, but I said in the young kids, our CPS does a pretty good job. You have multiple fractures in it. So I don't know if that's your experience here. That's ours. But the adult hospitals, it's very interesting what they report and what they don't. Very, very interesting. In a bad way, I think.
Thank you, Rachel.